Welcome back, everybody, to part 2 of our lumbar microdiscectomy. And if you remember when we introduced this surgery, I focused a lot on what leads to requiring any type of lumbar surgery. And if you remember, there were a couple of things that really stick out as things that surgeons are going to consider important reasons to provide surgery for a lumbar problem. And that includes what's called cauda equina, which is that bowel and bladder incontinence and sometimes sensory issues around the sacrum, as well as significant amounts of radiating pain. We talked a little bit about disc herniation and how it happens. I'm not going to go into detail again, and again, that can be a whole separate class, but just recognize that when we oftentimes need to have surgery for some sort of herniated disc or bulging disc, it's because that disc bulge has moved posteriorly into the area where the nerve root is sitting, and that can then lead to nerve problems. So that's kind of what this picture shows here, is that herniated disc that's pressing up against the back of the spine, the spinal cord. Some of these they can be healed by themselves without requiring any surgery, and that happens a lot, and so it's probably happening to half of us right now. We've got some herniation in a disc that is kind of healing on its own. If you do end up with herniation that leads to irritability of a nerve root, that can lead to pain down the leg, and if it's nerve root, it's going to be more of a radiating pain or sharp shooting pain. If it just herniates into the tissue around the disc, then it's much more likely to be more of this referred pain, not radiating pain. And this is a very old picture to show kind of where they might be presenting with that referred pain. The other option for when you will likely get nerve root issues and damage that might require some sort of microdiscectomy or lumbar surgery is with spinal stenosis. And spinal stenosis happens with our older patient population. There could be degeneration to the disc. You may have a disc herniation as well, but what tends to happen is that we get narrowing of either the central foramen around the spinal cord or around a spinal cord or spinal root, nerve root. So again, we talked about the primary patients that tend to end up with getting this surgery are not those with stenosis, but those who are younger who have had some sort of disc injury. What we also talked about, if you remember, is that an MRI is not necessarily going to be what drives the idea of getting a surgery. So there are a lot of research papers out there about the fact that MRI just provides us with some information, and that there's a lot of people out there, especially as you get older, who have disc degeneration or a disc bulge, but that doesn't necessarily mean that they have pain or symptoms or anything that might require surgery. And so if they are being seen non-operatively, which is a lot of these people, you may be performing things like the McKenzie exercises for those who are definitely showing referred pain from disc problems. You're also talking to them about how important it is to not be worried about this disc herniation. It's very likely that it will heal itself. And so a big part of our non-operative treatment is understanding how to be aware of stress management, mindfulness, and things like that. And what you're going to see today is that we're going to talk about our pre-op and post-operative treatment for our patients who have had disc herniations and require a microdiscectomy. And it's very similar. We're spending a lot of time on patient education with a lot of these patients who end up having the surgery as well as those who don't. So we talked about what's going to lead to the surgery. And again, I'm not going to go into a lot of detail. It's a very, very simple surgical procedure by most standards. It's very quick. They're usually done in outpatient. I've seen some really, really nice surgeries done here in China. So again, we're not going to go into a lot of detail, but basically they're just going in and taking out that piece of disc that has caused a problem, and sometimes they have to go in and cut a little bit of bone around it, especially if there's stenosis, to help open up the space around the nerve. So complications, this was kind of where we ended the last time. I don't see a lot of complications. Infection would probably be the main one. Infection just around the surgical site. Previous to surgery, and obviously after surgery, we want to make sure that they're not doing a lot of bending or lifting. And that really should be for about 6 weeks after surgery. But that's probably the main precaution. That's the main situation. So a lot of these patients will go home without a brace or anything, and they're going to be able to get up and start moving, but we want to avoid lifting, twisting, and bending, bending from the back, at least for the first 6 weeks. So we've got some great research out there. Adrian Lowe, who is one of, I would say, the most amazing pain scientists that's doing work right now, did a really nice case study in 2013 from the American Journal of Physical Medicine Rehab. And I just kind of want to go into some of the take-home messages that are now part of the literature when it comes to pain control with patients who have low back pain. So in this particular case study, and what they're noticing is very helpful now, is this idea of preoperative education related to neuroscience. So Paul and Joe and a couple of the other USC people, including myself, have done some nice presentations related to pain science, and it's a whole separate thing that we don't have time to talk about now. But what you want to really think about is that generalized pain pattern for patients who are presenting with low back pain. And those are the patients from our clinical practice guideline that are not presenting specifically with a nerve root problem or even a herniated disc with radiating pain, but their symptoms are kind of all over the place. And what they found with those people is that their brain chemistry has actually changed. And even with those patients who do have nerve root injury and or a herniated disc that require surgery, those patients' brain mapping has also changed. And so what we find is that we need to provide a good amount of patient education, and when we do that, we actually see changes in the brain chemistry that are for the good, and we'll talk about that specifically in just a second here. But what we're trying to educate our patients on preoperatively is this idea that if they've made the decision and the surgeon has suggested that the patient should be having lumbar surgery, we need to be okay with that. We need to own it. We need to say this is something that we need to do, and that's okay. We also want to educate our patient on the idea that there is something that's changed in their brain, likely because of this pathology, and so we need them to understand that as we have surgery, that those things hopefully will change back, and actually look a little bit calmer following the surgery. So their symptoms will decrease, and the pathways that are sending pain signals from the body are going to likely change. And we want them to understand that that's a good thing, that these are things that will help with their recovery, basically. And so there's these different ideas about sensitization of peripheral nerves. Again, I'm not going to go into a lot of detail, but this is something that you can kind of introduce to your patients as a reason why they might be experiencing their symptoms. So as we move into other education, we want to be able to give them ideas about how they can calm down their nervous system. And so we will do things for treatment that help to basically just get the whole system to calm down. We also want the patients to be able to reflect on how they're feeling through this process. And what's nice is that the surgeons I've worked with in China will actually have the patient fill out a questionnaire to make sure that they're appropriate for surgery. And part of that is just allowing the patients to sort of self-discover how they feel about their pain, because again, a lot of this pain is what's called centralized pain, and that pain can really affect how well they recover from the surgery. So if the doctor is uncertain psychologically that the patient's going to be able to tolerate it, then they often choose not to do surgery. So the research that I referenced earlier, again, it's Adrian Lowe and colleagues did this one case study, and here's what they found. What you see here are fMRIs, so functional MRIs of the brain. And in the pictures on the left, this is before they were provided with any education related to their problem. Remember, this is just education. This is not even the surgery itself. This is just education related to what's going on in their back. And what you'll see is that certain areas of the brain, in the first two pictures on the left, were very, very hyperexcited. And basically what they are, places like the cerebellum is where signals go to our cerebrum. So they move through the cerebellum from our body, and they are things like pain signals. So the signals that are coming from the spinal cord from a certain area of the body come through the cerebellum and then out to our cerebrum, oftentimes to help us understand our pain. And you'll see that the cerebellum is very, very lit up here on the left. But then once these patients were given some education, again, we don't have a lot of time to go into all that education stuff here, but once they were given that pain education, you can see that their cerebellum calmed down a lot. But in the last group of slides, or the last group of pictures here, on the left, that's our cerebrum, our cerebral cortex, or our motor cortex. And you'll see that that's actually pretty quiet. But once we educate patients on the fact that this is not a pain problem, we actually end up turning on the motor cortex more. So meaning motor cortex being where we're able to get movement, where we're able to perform good movement. And what we're finding is that people actually start to move more and start to allow themselves to perform good movement just by getting the patient education about the pain science behind it. So again, we don't have a lot of time to talk about this, but there's a lot of things that affect pain, and most of the research these days is about low back pain and pain centralization issues. But recognize that any type of pain that's happening anywhere in the body can be presenting like these fMRIs pictures, where we have these areas of the brain that are lit up and hypersensitive that are much more related to their pain than any type of tissue damage. And so that's important to recognize all the different aspects of pain. And it's definitely, with this patient population, going to help make your outcomes a lot better. Okay, so let's get into the surgery. Our first phase following this surgery is the first 3 weeks. And I will tell you, hopefully you can get these patients in the first 3 weeks. It's a really nice to be able to start doing rehab early with them. Hopefully surgeons are allowing early rehab, because again, this is not a very invasive surgery. They call it minimally invasive surgery for a reason. So these patients should be up and moving very quickly, and we hopefully get them very quickly after surgery as well. Sometimes even the same day. So we were seeing patients literally the same day after surgery and giving them kind of a basic home exercise program. So our goals during this time is obviously to manage pain, decrease edema, and try to make sure that they can tolerate upright postures. So things like standing. We're not going to do as much sitting, but standing, and not have a lot of pain. And again, we're doing a lot of patient education about fears related to their pain. We want to make sure they understand good body mechanics, because at this point, as I said earlier, for at least 6 weeks, they're not going to be doing a lot of bending from the back or twisting, but they can certainly still squat and do, obviously they need to be able to get on and off a toilet, things like that. So we want to make sure they understand how to do that without causing too much compression on their disc or the tissues around the low back. So our other big goal is to restore range of motion, make sure that the lower extremities, we're strengthening the lower extremities. And remember, a lot of these people, the reason that they're choosing to do surgery is because there might have been some myotomal weakness, meaning certain muscles related specifically to a nerve root became weak. and they might even report, decreased control or balance with weight bearing. And so these are the kinds of things that we want to address early in rehab. Start making sure that strength is that we're increasing strength now that they have opened up the space around the nerve root or the spinal cord. And so that's a big part of our treatment. Patient education, again, we're just going to keep pounding this home. It's so important that the patients understand that hurt does not equal harm, that now that we've had the surgery, the tissue is healing, and there shouldn't be any reason why we can't start doing more movement. And being able to get up and move is actually, again, going to help the brain to heal and change its signals as well. So we really want to be encouraging them to walk and walk and walk and walk during these first phases. And you'll see that that's the primary treatment really for a lot of these people. We also want to make sure they understand that the numbness and tingling doesn't always go away 100%. So if they are having those symptoms in their leg, that's normal, and that will go away eventually. So we can provide treatment for that if needed. Okay, so treatment is mostly a lot of body mechanics. Make sure that they are keeping some sort of lumbar lordosis and avoiding trunk flexion and sitting. And again, I would say we kind of try to discourage prolonged sitting no matter what during this period, just again because it provides more compression on the disc. We also can do some passive range of motion stretches for the lower extremity. Remember, we're kind of letting the low back heal and not move as much, so we need to make sure that the areas above and below are moving well. So we're going to spend a lot of time doing range of motion things at the hip, as well as standing stretching for like the gastroc soleus and things like that. We can stretch the dura. So again, you can do some straight leg raise type things where we're stretching more through the nerve or around the nerve. But we can also stretch the dura throughout the whole spine. And we can do that. We don't want to be doing that in sitting, like a slump would not be a good idea after surgery like this, but we can do some of those things in supine. I also really, really love quadruped for these patients. Quadruped is a very comfortable position and tends to be tolerated very well. You can put them in a little bit more lumbar lordosis, and then you can do lots of different exercises in this position. The other idea is squatting. You can do small squats, so 60 degrees or so is totally tolerated, or should be allowed at least during these first 3 weeks. And a walking program, consistent walking program. They should be doing a certain amount of meters every day and increasing that daily during this first phase. So our goal to move on to the second phase is going to be pain control with ADL. So they really should be back to pretty much all ADLs except for maybe lifting at this point. And they should be able to demonstrate that proper posture and body mechanics. You're also teaching them abdominal bracing. So you're teaching them how to turn on muscles around their spine. And they found with research that even with a small spine injury, that the multifidi especially, that help to stabilize and control our low back, they kind of tend to turn off. And so we have to come back in and educate and kind of teach the patient how to turn the multifidi on, sometimes the transverse abdominis. And so those are all things that we're teaching during the first phase. So second phase is going to be week 3 to 6. So again, this one lasts for about 3 weeks. And what we're really spending our time on with this one is more advanced neutral spine activities. So we want to make sure that they're getting, they're understanding what a neutral spine is. And again, that was originally discussed in the first phase. And then we're starting to perform more advanced activities using that neutral spine where they're able to turn on, again, their transverse abdominis, their multifidi muscles. If we have the opportunity to do a lab, we'll definitely be spending a good amount of time going over what that looks like. During this phase, we also want them doing some sort of cardiovascular exercise for at least 20 minutes. And again, sitting is not smart. So if they can get in a pool or just do walking or get on an elliptical machine, all of those things would be much better in terms of their treatment. We also want to make sure they don't have any more nerve symptoms by the end of the 6-week period. And So we're going to be checking for any nerve tension and providing either nerve glides or maybe soft tissue work around where the nerve is irritable. So our patient education, again, we want them to understand how important walking is. And then we may end up doing some cognitive behavioral therapy. Again, this is kind of out of the realm of what most of you probably are doing, but it is important to be aware of it. And we do have other classes through USC that will help to teach those things if you want to be involved in those. So we're progressing our core training. That's the primary treatment. Core control with lower and upper extremity movements. And we're also making sure that the lower extremities are very strong. And again, we're looking for any myotomal weaknesses that might have occurred previous to surgery. So here's just a couple examples of things that you can play with. Some of these I'll even do during the first phase. We want them to learn how to lift correctly, how to lift from a squat. And so at this point, during this phase, they can lift up to 2.5 kilograms. We also are going to make sure the hips are moving well. Again, this is similar to the first phase. We're performing nerve mobilizations if necessary, but a lot of these people, their nerves are actually, they calm down very quickly. So if they've got a good surgeon, most of the time, within a week, they don't have any more nerve symptoms. So to progress to phase 3, we want them to have great control with great pain control with all things like ADLs and physical activity. So all the stuff you're giving them, they really shouldn't have pain. They should be doing at least 20 minutes of aerobic exercise, and we want to make sure that they understand what their posture should look like when they're performing the activities. So phase 3 goes from week 7 to 12. So this is again up to about 3 months. We want consistent body mechanics with all ADLs. They should be able to do all ADLs. They should be able to, at this point, by the end of 3 months, return to all previous level of activity. And of course, if they are injured workers and they have to do a lot of lifting, or if they are some sort of athlete that does a lot of rotation through their trunk, we want to wait until this phase and later to really be working on the more advanced side of this. So don't expect those things, those types of activities to be completely successful at the end of 3 months, but we really are working our way towards that success. We are going to be working on lifting. We are going to be working on some controlled rotation during this phase, but recognize that those are more advanced activities. So all of your basic activities, like the picture shows here, things like mopping and sweeping, those kinds of things they should be able to do. So again, we're just progressing our core activities. We're getting them on things like an elliptical trainer, and we're basically making sure that they're back to their normal ADLs. We're also going to start doing things like chopping, which is a rotational movement, and possibly some light lifting. And it's this phase that we want them to be able to show that they can do everything in their daily life without pain. And at this point, they're going to be going to return to sport or return back to work, so some sort of work conditioning program. And that sometimes might be something that you're doing, or it could be something that they do on their own if it's not appropriate for us to be continuing to see them. But it's really important that they understand that these activities are going to actually help the health of their back for many, many more months and years. And so they kind of want to keep going with them. And remember, there's a lot of these people who have a lot of pain before the surgery, and the idea is that we're spending a lot of time making sure that the brain is calmed down and that they can participate in the things they want to be able to do. And so the last phase, the sport-specific training phase, is going to be any time after week 12. And we're doing these fun exercises like more heavy lifting, the Turkish get-up, which is one of my favorites. That's a picture of it there. That's a great example of a way to really make sure that the back is stable. And then we're going to also start adding in things like hopping and jumping. And if they need to be able to do those things, this type of impact is something that we do really wait until about 3 months before we do that. So they should be leaving your office and discharged with a walking or running program if running is appropriate. And there's a couple of nice little references out there that can give you ideas about how to do that. So this is just, this is the number of daily steps. This is kind of the recommendation for different age groups. This is if you want to get 10,000 steps in a day and you're under the age of 65, then it kind of shows you how to progress your walking. And I think we all know that 10,000 steps a day is kind of the goal for most of our patients. And so this kind of just gives you an idea of how you can do that. So I have a lot of references here. You'll see there's 2 pages of references. You guys should be able to get these in your with all of your other information so that you can kind of refer back to these. Again, there's so much new research about pain science, and I just don't have time to go into it here, but it's important that you recognize that these patients will be requiring a good amount of education that's not necessarily specifically related to anatomy, but it is related to neuroscience. And so having a background on that with this patient population is going to be very, very helpful